Thank you very much, William, and thank you all for coming. I hope that this is not has some relevance to you in your work. I was just wondering how many people here in the audience are just urgent care, and some of you do more normal hours GP work? Okay, great, because some of it is a little bit more related to normal hours GP work, but we'll see how we go. So my declaration of conflicts of interest, I could put all sorts of things down like here, couldn't I? But really relevant for this meeting is that I do work for Healthscope New Zealand. I used to work part-time at Middlemore, but I don't anymore. I work full-time for Healthscope New Zealand, which is, Healthscope New Zealand covers about 70% of the community laboratories and some hospital laboratories in New Zealand, and is part of a wider company of Healthscope Australia. And our contract with the GPs is bulk funded with a collar and cuff funding model. And I think this is quite worthwhile noting. I had a conversation with a senior colleague the other day who I've done quite a lot of work with in the past, and we were having a discussion about a program which I think will lead to an increase of a particular test. And I said, oh, you know, we're not going to be funded for any of this extra testing. And he said, but aren't you funded per test? And I was like, no, no one's funded per test anymore, really. So this is the collar and cuff model. I can never remember which is the collar and which is the cuff, and this is my lovely picture, that drawing here. But basically, the aim is to keep the testing volumes, recognising that they go up a little bit with population growth, but to keep them sort of in these tracks. If it goes below that, so we do fewer tests than is expected, we give the DHBs money back, and if it goes up, the DHBs have to give us some money. So it's a kind of a risk share approach to demand and to controlling volumes that we have. So laboratories, it's quite hard to get this information, but laboratories I think are about 4% of the overall cost of publicly funded healthcare in New Zealand. And obviously they're very important in the diagnosis of disease and pre-disease states, and that's sort of what screening's about. But a diagnosis is not a cure, and I think that this is something that, as there's been a proliferation of laboratory tests that are available and radiology that's available, I think sometimes we slightly forget this, that you can have a million HbA1cs, but unless you actually do the right things with your diet and your exercise, you've still got diabetes or pre-diabetes. And I think about this in terms of myself actually. I've got so many pairs of running shoes, and the reason is that I think every time I buy a new pair of running shoes that I will be a better runner. But it doesn't work like that. The only thing that makes me a better runner is if I actually go jogging occasionally. So yes, diagnostics is important, but it's actually only important if we do something with the result and we do something appropriate with the result and we have patient compliance. And I think that another thing that sort of crept in with the availability of laboratory and radiology and other diagnostic testing is that we do sometimes tests like, oh, just in case, or it would be nice to see a negative. But the test, I think it's important to think, will the test result make a positive difference? I did my physician's exam prior to my pathology exams, and there were quite a few people that were surprised that I passed on the first round, including myself. But I think one of the reasons I passed is because I worked out that with those multi-choice questions, the answer, if it was a diagnostic one, the answer was always the definitive test. So it was always, what's going to make a difference to this patient? I worked that out, and once I worked that out, I used to get the answers right. So I think that's something, is the test going to make a difference? Are you going to act on it? This is my attempt at, Metro magazine and the Sunday Star Times back in the day when I used to read it, what's going up and what's going down. So I think we need to acknowledge that demand management is here, it's here to stay. It's in all the community laboratories contracts, the private provider contracts with the DHBs. There's a Northland and Auckland regional demand management group, which I'm a part of, which has come out of the joint advisory group for laboratories for the Northland and Auckland regions, and so you'll be seeing more and more come out of that. I think another thing that we need to think about, and when I say we, I know it's a little bit easy for me to say because I don't have conversations with patients except for the ones that try and phone me to yell about the times that waiting for their blood tests to be taken in the collection room. But I do hear from GPs sometimes saying, I only did that test because the patient demanded it and I didn't actually think it was relevant and I didn't want to do it. And I think it's really difficult for the way the structure is set up because GPs are a business. However, I also believe that we are professionals, and by just saying, oh shoot, I'm feeling the pressure, I need to do whatever they ask, is actually devaluing our profession and devaluing you as professionals. And I know it's very difficult because time is such an issue, but I think conversations with patients around expectations is quite a valuable thing to do. And I'm not sure if the GP College in New Zealand has done anything around this, but the GP College in Australia has put together some good documents about what to do when patients come asking you for tests that the naturopath has ordered, but they want you to order them so that they don't have to pay for those out of their own pocket. And that includes actually a piece of paper that you can give the patient as well, explaining the background and how, I mean, it's a little bit Australian-centric, but it's, I think, quite useful. Laboratory personnel, your colleagues, I was the worst at this actually. When ANC and I, we worked at Middlemore together, didn't we? I used to phone the lab and say, where's my troponin? Where's my troponin? But now I realise that that's actually quite bad manners. Clinical details. The lab staff love seeing clinical details. They'll read them and they'll come and say, oh, Arlo, we've grown this and it's the GP's written the patient's on Augmentin, so can we put out that comment saying da-da-da-da, or shall I give them a ring? So they actually do get read. Going down, I've got the patient rest home hospital told me to. I just don't think that that's how we should act as professionals. And being grouchy about lab tests, although if you have genuine concerns, you can get in touch with me. And we do have a very robust process of dealing with complaints. So we take all complaints seriously, and where it's a complaint, rather than just I had to wait 15 minutes for my blood test, there is always a feedback process as well. So demand management, which is the very naggy, actually this whole talk is unfortunately a little bit naggy. I'm nagging you, taking the pressure off my husband. So demand management is not actually necessarily about restricting testing across the board or restricting antibiotic use across the board. It's about trying to look at appropriate resource allocation. So appropriate resources for everyone, not just those who lobby well. And because I'm laboratory, I end up meeting or going to meetings with all these different groups of lobbyists. So on Thursday, I had a hepatitis C meeting, and they were all basically saying the government should be paying for everyone to have hepatitis C testing. The government is slightly silly. The taxpayer should be paying for everyone to have hepatitis C testing, and everyone with hepatitis C to have a course of therapy. It costs about $110,000 a year for a course of therapy. Then I went to see the midwives, and they were okay because they were only students, so they weren't quite at the lobbying stage yet. And then I had a break, and then I went to see the sexual health HIV people, and their plan was that every person in New Zealand, aged 15 to 65, should have a mandatory HIV test every 5 years. And I was like, guys, that's a colossal waste of money, and that money would be much better spent on HPV vaccination for boys. So there's a lot of lobbying going on, and it is a little bit of a balance, because these people are very genuine, but they only genuinely think about their own area, their hepatitis C or their HIV. And actually, appropriate demand management can increase resource utilisation in some areas, and I'll touch on that a little bit later. This is my Treasury graph stolen from a 2013 document. The health spend has increased more than GDP, and that is a bit of a problem unless, as a society, we think that spending money on healthcare is more important than spending money on education and housing and jails and da-da-da-da-da. So sort of moving a little bit more into microbiology. So laboratories have had quite a lot of technology in the last few years, and it's mainly affected chemistry and haematology. But microbiology and anatomical pathology have remained quite hands-on, labour-intensive areas in the lab. Recently, technology has come to microbiology, so we've got more automation, and also molecular diagnostics are becoming a reality, and so we've got two areas of the lab that I'll talk about. We don't have this, but my colleagues in Bay of Plenty Path Lab, they have this track thing that the swabs and the urines and things come in, and basically a robot basically deals with it as it goes through the lab, puts it in the incubator, takes it out of the incubator, takes photos of it. The person looking at it on the computer screen can look at a plate with, you know, a Staph aureus growing, and can circle that and say, I want that picked up, and then the robot will pick up that bit of Staph aureus and do the susceptibility testing. And so actually It's actually got quite a few implications in terms of workforce, but we actually have too many specimens and the robots are not as fast as humans, so we don't have that. Sexually transmitted infections, I think, is quite a big area for me in the micro lab. And it's an area that we've sent out a consultation document to stakeholders recently, and if anyone hasn't seen that, if they could email me, I can get you a copy of that. And it's an area where the technology is changing, meaning that the way we do things is a little bit different. For example, endocervical swabs are really kind of a thing of the past in most circumstances, but we still have a lot of people doing endocervical swabs. So NAT tests are nucleic acid amplification tests, of which PCR is the one that we think of, but there's lots of different kinds, and quite frankly, I don't quite understand how they all work. They amplify either RNA or DNA, and the sensitivity of the test is excellent. So we pick up probably an extra 20 to 30% of gonorrhea with the move from culture to PCR. But the specificity is excellent, and I've got some other slides to show that. But with gonorrhea particularly, there's some theoretical reasons why it can be a little bit problematic. And the positive predictive value is something, prevalence and positive predictive value is something that we think about all the time, and I don't think referrers think about as much as they need to. And again, so I get a phone call yesterday from a GP saying, I've done a chlamydia gonorrhea test and it's positive, and what am I going to do? I don't think she's got chlamydia or gonorrhea. And I said, well, why did you do the test? Oh, because it was a routine smear. Well, you're not supposed to do that. So, you know, if people are doing tests and then as soon as it's positive, they're going to phone me and say it's a false positive, it's starting to irritate me slightly. But you shouldn't really be doing a test if you're not going to believe a positive result. And I'm not saying that there aren't false positives, because there are. We've got a very nasty problem with false positive at the moment, causing an HDC complaint, and the lab made a mistake. It wasn't me, thank God, but someone else made a mistake, an unforgivable mistake. So I'm not saying that we're perfect, because we're not. But I think that this issue of positive predictive value is really important for you guys to understand. And this is a little chart thing that I made, a sort of a hypothetical chart, and it shows the impact of prevalence on positive predictive value. Now remember, positive predictive value is what's the likelihood that a positive result represents a true positive in an individual patient. And so you can see where a test has got, table 1 is where a test has got 99% specificity and where a test has got 99.9% specificity. And 99.9% specificity is an incredibly good test. So our HIV screening test, Hep C screening test, they have those kind of specificities. But we do see false positives, and we see false positives because a lot of tests are being done on people with very low prevalence. So if you take the 99.9% specificity and you look at a population with a prevalence of 0.3%, and that is the prevalence of, say, gonorrhea among middle-class white women, middle-aged, middle-class white women, the prevalence is actually quite low. Your positive predictive value is only 75%, so a quarter of those positives in that group will be false positives. So you shouldn't be doing the test unless there's symptoms which will bring up your pretest probability in that group. And I think this is a real issue. We need to move away from routine chlamydia and gonorrhea testing with smear tests. It's something that's snuck in. My GP offers it to me, and she's done them in the past, and now that I know a little bit more about it, I say, no, I don't need it, thanks. But it's something that's really snuck in, and the idea is, oh, negative tests are great. Negative test is great, but what do you do when it's not a negative test? This is, we've got 3 machines. They're called Panthers for the chlamydia and gonorrhea, and they also can do trichomonas and mycoplasma genitalium. So this is a change in machines, and when the machines change, everything changes, as you know. So there's that's the urine kit, and that's the swab kit. And just to remember, it's the blue swab that has to go in. This is to clear off mucus, because mucus in theory can stop the technology from working. So the white swab either gets discarded or clears off mucus, and then the blue swab goes in. I can't remember what I've got here. I was going to say, for men, remember that for men doing chlamydia and gonorrhea testing, all you really need is that first catch urine, that's it, except for men who have sex with men and then you start doing rectum and throats and things. if they have symptomatic urethral pus or urethral discharge, you can do a bacterial swab of that for gonorrhea culture and just send the first void urine in that one. For women, I think if they're having a speculum exam and there's pus coming out, yes, do a normal bacterial swab, but otherwise, unless that's the case, the test of choice is a vaginal swab, and that can be self-collect, doctor collect, nurse collect, best friend collect. It doesn't matter. And it doesn't have to be, it doesn't have to, endocervical is not needed. So vaginal swab, and the sexual health physicians actually say waving it around the area is probably sufficient. The sensitivity of the test is so good. So it really actually simplifies things. So who needs testing? Well, I was going to put down every Tom, Dick and Harry, but then I realised that wasn't appropriate for this talk. So I had to Google and find out what the female versions of Tom, Dick and Harry are. But I think that this is a big thing. These tests are really, I think they're the second most expensive test we do in the lab. We spend nearly $1 million on these tests a year. And that's just the consumables. That's not the electricity or the staff wages or anything like that. Expensive tests. They do not need doing on people having routine smears unless they fulfil the other criteria, like being under the age of 25, having STIs in the past, having partners with STI, all those other things. I think, and I'm going to show you some data, some women are having millions of tests, and some people are not having enough tests, and in particular men. And I was quite startled when I saw these data. So we recently, at the beginning of the year, went through an ethics process like a good girl, and we tested 3,500 samples from patients aged 13 and over that had been submitted for chlamydia and gonorrhea. We also additionally tested them for trichomonas and reported that. And then subsequently, with an ethics amendment, we also tested them anonymously for Mycoplasma genitalium, which was not reported. And then we had a look at the testing volumes and results in terms of ethnicity and to some extent in terms of NZ deprivation data. So those ethnicity and NZ dep data come from the Ministry of Health. And you can see that the blue boys, this is META, that's Middle East, Latin America, African, which is a smaller section. And these data are, there is a denominator of population in Auckland, so those population data we got from ESR. So it's actually very accurate because it doesn't just give you, numbers, it gives you proportions or percentages. So you can see that with the exception of these groups of people here, the men among Europeans, Māori, Pacific and Asian are not having very many tests at all. You can see that Māori women and Pacific women are actually having quite a few tests. So I don't think lack of testing is the issue as we go forward and look at the rates of infection. And looking at that, you might say, there's quite a lot of testing actually among European women. I haven't put down the male STI prevalence, but this is the female STI prevalence in terms of age, and the different bars represent the different organisms. So you can see that gono, actually, the red one, is actually more in the 40 to 45-year-old, so the 30, 35, 40-year-old age group. But the rest tend to occur in the younger age groups. I don't think anyone would be surprised to see that STI prevalence goes up with deprivation score, and again, these are the different organisms. So that's chlamydia in blue, and that's gono. So we actually don't have a huge amount of gono in our community, but it is quite high in those groups that are most deprived. And then I think these are the really alarming data, is the STI prevalence in Auckland and Northland with respect to ethnicity. And again, this is reported in per rates of population, so it's kind of real data in terms of understanding the rates of different ethnicities, proportions of different ethnicities in our community. So that Māori and Pacific, particularly the Māori, is quite alarming really. And so I sort of was thinking, I wonder why this is. And again, looking at those testing rates among Māori women, they're actually quite high. And I think that primary care's done a very good job with probably working with getting pap smears on Māori women and getting testing. But I wonder if the Māori men are not being tested, and that's a sort of where the infection is continuing to spread from. Possibly, I don't know. That's supposition. So who should be tested? Obviously people who are symptomatic or recent exposure, high risk behaviour, young people, the guidelines 25 and younger, men who have sex with men, Māori, Pacific, Mila, ethnicity, and people from relative social deprivation. And I think this is something I was discussing with the STI lobbyists the other day, and I can't take a sexual history. I remember trying to take a sexual history a couple of times when I was doing the hepatitis clinic, and I just wound myself up in circles. But these sexual health nurses are actually very clever, and there was one sexual health nurse I was talking to, and they've got all these quite smart ways of opening up a conversation about sexuality and sexual history, with it being very non-judgmental and kind of very normal part of the conversation. And they do training, so I thought if I ever did do clinical medicine again, that would be something that I would do, because I know that that's something I feel really uncomfortable doing myself. I'm moving on a little bit now to tuberculosis diagnostics, and this is one of the things that's come out in the recent consultation documents that we sent off on Friday, which is not just from me at Labtests, but is from the demand management group, and so it's Labtests and Lab plus the Auckland Hospital lab predominantly. And you know, as we know from our history, tuberculosis has through the years ravaged humanity, and so people are understandably quite worried about TB. But I think it is a little bit of a misunderstood infection, and the diagnostics are very misunderstood. So tuberculosis infection, so a third of the world's human population is supposed to have been exposed to TB. India and China and the Philippines, I can't remember if it's India or China which one tops, and then the Philippines I think is the country in the world with the third to highest prevalence. So you can be exposed to it as a child, you might feel a bit unwell, it gets walled off, it gets controlled by the immune system, and you've got latent tuberculosis infection. If it reactivates later, that is disease. Or you can acquire it and just get immediately sick. But what, in a country like New Zealand, one of the main things that we're doing testing for is latent tuberculosis infection, where it's dormant, the chest X-ray is normal or nearly normal, and the person is clinically well to all intents and purposes, but it could reactivate. So I've got these nice pictures of these lovely Auckland volcanoes reactivating. And this I was stolen, I actually very naughtily haven't put a reference, but it's quite nice because it shows the kind of balance between disease and your immune system, and how it is a continual balance there. So that's one of the reasons why patients who are about to go on those ghastly TNF-alpha type blocker drugs, they do have testing for latent tuberculosis infection, because if those tests are positive, then they get treated to prevent reactivation when they become so severely immunocompromised. But someone else who, say, is well and healthy and in their 40s and did their elective in India and has a positive quantiferin gold and has got normal chest X-ray, then even though they have the positive quantiferin gold, you almost certainly wouldn't go on and give them TB treatment, because you've got to remember that the TB treatment you know, can cause liver damage, and there's the odd person who dies of liver failure from those drugs. So reactivation, overall the reactivation rate is supposed to be up to 15%, but it's higher if you're younger. It's higher in the first 2 years from when you acquired the TB, so that's why with my example of the medical student who's now in their 40s, you know, they acquired it when they were in their 20s, when they were in India on their elective many years ago. Immune compromise, and then if there's evidence of old TB on chest X-ray, it's just evidence of a higher disease burden. So those are the people that are more likely to be offered treatment for latent tuberculosis and therapy. I was actually going to put, this is a picture of Val Kilmore, and I was, when he was young and delicious and slim because of his TB infection, and I didn't get a picture of how he looks now, but he looks quite dreadful. I think he had too much to drink, actually. So quantiferin is an IGRA test, which is a test that measures your T-cell activation in response to TB antigens. And it came out in it with a hiss in the raw. I think it was originally developed by, I think it's an Australian company, and it came out with a hiss in the raw when I was a registrar, so quite some time ago. And and it was kind of promised to be this wonderful test that was going to replace MAN2 testing, but actually it has many of the same problems that MAN2 test has. The only thing it doesn't have is it doesn't have the cross-reactivity with the BCG as the MAN2 does. So I had BCG, my MAN2 is massive, but my quantiferon on the one time I did it was negative. So it's supposed to be used pre-employment screening, and that is really misunderstood. But basically it's supposed to be if you're going to be a doctor or a nurse or a physio or whatever and potentially come into contact with TB cases, it's actually, the pre-employment screening is actually to provide a baseline in case you get sick or in case you are involved with an exposure, so that you can have a follow-up test and that can be compared to the baseline. So that's actually why all the medical students have to have it done and everyone else has to have it done. It's not to see if you are immune, which is what some people believe, and it's not to see if you've got latent TB. It's less so to see if you've got latent TB. Now, if you go to if you're, say, from a country of high incidence and you're going to work in America or in New Zealand, then it's to see if you've got latent tuberculosis, because it's a question of whether you're going to go on and expose people if you reactivate. But by and large, in New Zealand, it's actually a baseline. It's like when you have a needle stick injury and you get, immediately after the needle stick injury, you get your Hep C and Hep B and HIV done. That's to prove to ACC that you don't have any of those, so that if you get them, then you'll get ACC. To be honest, most of the quantiferons we do, similar situation. Pre-travel, immigration, so that's for protection of public health, and contact investigation. Now the first three are all commercial tests. They're not covered by the Ministry of Health DHB publicly funded testing. So if you guys are ordering it, it should say patient to pay. Not everyone's doing that and some are sneaking through, but actually that's not covered by the DHB contract. And the last one, the contact investigation, is public health. So primary care is not supposed to do any contact investigation of TB cases. Even if someone comes to you and says that I was in China and someone came round for family dinner and then 2 weeks later was diagnosed with TB, you're supposed to phone public health. They get quite sniffy. So you guys are not supposed to order any tests. So in theory, there's actually not a reason for GPs or urgent care to be ordering quantiferon golds. Is it a marvellous test? As I said, we were told it was a marvellous test. I think it's a pretty crap test, actually. The reproducibility is terrible. And it's partly because these assays are just hard to have good reproducibility, and don't ask me any questions because I don't actually understand the laboratory kind of nuts and bolts of that. But if you take, we'll do a test on Ainsley, and we'll do a test, take some blood from Ainsley and we'll run it today, and then run that same blood the next day, you see variability there, so sometimes it'll go from negative to positive. Or you do your test on Ainsley today and then repeat it in 2 weeks' time, you see a change from positive to negative, etc., etc. So these are where tests were done under exactly the same conditions, and there were over 700 subjects with 2 tests, and 6% of them were different results in the same people. And it's particularly where it's around the cut-off that you see this variability. So if you get a really strongly positive, it probably stays positive. If you get a weakish positive, then chances are it's kind of possibly a rubbish result. And then there's some studies that have come out looking at all these tests that have been done on healthcare workers, and again, you get a negative result, yippee yay, we've got a negative result. Except that sometimes when you repeat that test on the same person a couple of weeks later that was negative, sometimes it becomes positive. And then when you get positive results and you repeat those a couple of weeks later, sometimes they go negative. So in these studies, the ones that stayed positive were the ones when the patient or the healthcare worker had a positive MAN2 and a positive quantiferon, or a positive quantiferon and a good history, either a good exposure history or a good travel, grew up in China history. So it's actually not that fantastic a test, and I'm telling you that it causes more trouble than it's worth in primary care. So you won't be sad to know that the plan is to, following consultation, to restrict that testing in primary care. And that's just the same thing really, so I won't go into that in great deal. So the diagnosis of TB, if you have a patient who's presenting, so if you're looking for latent TB, which we've already discussed you won't be doing, then, well, you're not doing it, so it doesn't matter. But so the only way where TB and you guys is important is people present with clinical signs and symptoms that could be TB, and that is TB disease. And this gets back to my old comment about the FRACP. Don't do some stupid test around the edges, you do the test that makes a difference, and that is the biopsy or the sputum culture. Like, people have this desire, and I think all of us do, I'm sure I'm very guilty of this as well, is we'll check that one and that one and that one. You just have to do the one that tells you. So the person who's got the adenopathy, they need a biopsy with histo and culture. And the person who's presenting with cough and hemoptysis, they need sputum culture, but they don't need quantiferons. Because like the man too, when you've got active TB disease, the quantiferon can be negative due to complicated things to do with T cells that I don't understand. So that's TB. Now we'll move on to my favourite topic. Do you know that I've been banned from, in our journal club, which is ID and micro, and public health come once a year, and we've got these rules that Arthur Morris created years and years and years ago, and it's no HIV, because I think he was never interested in HIV. No HIV, no organising it the night before and doing a crappy job. And now there's a new rule. Arlo's not allowed to talk about urine because every single paper I present is about urine, and I'm sick of it. But we receive over 300,000 urines from Auckland a year. And I did a little study where I looked last year at urines from people over 70, and of which there were a lot. I think about 20% of the urines come from people over, 20 or 30% of our urines come from people 70 and over. And for a small portion of them, I phoned or sent out a questionnaire or phoned the requesters, and in about a third of those, there was no clinical indication for the urine being sent. And my clinical indications were very generous. It did include confusion. So, but I suspect that urgent care is not actually as naughty as some other people in primary care in sending urines without clinical indications. Pre-analytical errors are a problem. So pre-analytical errors are the errors that we don't have to take responsibility for. And basically with urine, it is urine that has not been collected in a clean way, and you have a contaminated urine sample, and it's essentially difficult to interpret, which I will go on to the slide slightly out of order, but I'm just going to cover dipsticks because I know that along with the lack of collection centres and the wait times, I know that dipsticks are one thing that Labtests has done that has really pissed people off. But dipsticks are sort of a point of care test, and the dipsticks that big community laboratories do is exactly the same dipstick as what is done, like it's exactly the same technology. There are machines that automate it, but it's still exactly the same technology. So if we do it, the only difference is that it's slightly more automated, and the way the result comes, it gets put into your laboratory information system onto the computer. But in every other respect, it's exactly the same test. And when you think about it, what does it tell you? Ketones. It tells you if someone's starving themselves or if they're in diabetic ketoacidosis, but there are other better ways of establishing that. Specific gravity tells you whether they've been drinking too much water or not, whether they've been at a rave and taken ecstasy. pH, I don't think it tells you anything. Leukocyte esterase and nitrates are for white blood cells, and the nitrates come from the gram-negatives in the urine, so that's infection. Hemoglobin, we know that it's a completely useless test, not overcause hematuria, and glucose a finger dipstick is you know, a more appropriate test anyway. So that is our justification for that. And I think I had some communication recently around this, someone expressing understandable irritation. It wasn't not understandable, it was understandable irritation in terms of workflow and in terms of some complicated things around immigration. But one of the things I did say is that it's not just lab tests, all laboratories are looking at urines because it is such a common sample that takes up so much resource that we all have to look at how we're doing our urines and where we can make some savings. And so we have no dipstick, microscopy on everyone, because I think microscopy is actually important, and culture only where there are clinical details like neonate, pre-terp, pre-orthopedic surgery, which is very controversial, and pregnancy. One of the things, I was at a meeting recently with my microbiology colleagues, and this is one of the things that we touched on, was whether we should reject urines with high epithelial cell counts, and I think we should, which is probably quite controversial, but epithelial cells are a surrogate marker for mucosal contamination of the urine, and the cutoff is 10, but that's obviously arbitrary because it's a continuum. But if you have say more than 50 or more than 100 epithelial cells, All the other parameters are uninterpretable. So I wouldn't say reject urines with epithelial cells of over 10, but I might look at, say, over 50 or over 100. So nearly half of the urines we receive have got epithelial cells over 10. And this is just, I know it's harder for pregnant women or people who are not very mobile or people who are obese, but it is poor preparation. And it kind of just means that crap in, crap out. And you can see also of these data that excluded chilled babies. I think I didn't have people under the age of 1. A quarter had mixed growth, which is another sign of contamination. So the urines that we're getting in the laboratory are poor quality, and sometimes it's leading to unnecessary antibiotics and or leading to patients having to submit another urine, which is annoying for everyone concerned in the whole chain of things. And these are data that I looked at where I collected urines from asymptomatic women working at Labtests and looked at whether they had, I haven't got, this is epithelial cells fewer than 10, this is 10 and more, and you can see the white cell count where they have hardly any epithelial cells is sort of 30 and under, which is what we use for our cutoff. And you can see that these are asymptomatic women at work, racing around doing their chores. Where they had loads of epithelial cells, they had loads of white cells, and exactly the same thing for red cells. So it shows that these contaminated urines are largely uninterpretable. And so we get these requests for TB urine cultures because of sterile pyuria, but when I go back and look at the previous urines, they've all had 60 epithelial cells, 100 epithelial cells. So it's not actually sterile pyuria. Well, I don't know if it's sterile pyuria or not, because it could just be in the particularly crappy sample. Well, it is a crappy sample. I mean, there could be sterile pyuria under it, but we don't know. And I actually think it's quite hard to produce a good urine sample. But, you know, it's also hard to go and wait in line for 20 minutes and have someone stick a needle in you. And I think that that is actually one of the reasons why we have lots of urines, is because it's considered a relatively easy test to collect. I tried to find on Google Images pictures about how to collect a proper urine sample, and there's really nothing there. But what I recommend, so the data around cleaning is very inconclusive. Some studies around perineal cleaning show reduction in contamination, some don't. One of the scientists at Middlemore once said that she recommends particularly pregnant women to have a shower first, and I think that's good advice. So consider cleaning, go to the toilet, hold the labia apart, and I think this is the most important bit, start the stream and then stop the stream and get the bloody thing underneath and then put some in, and then, so I think it's quite confusing, but that is actually what needs to be done. So that's urine, and how are we doing for time? Oh, I need to speed up. So stool specimens, we get 100 stool specimens a day, Monday to Friday, and a few on the weekend. And some of them are not from people with gastroenteritis. People with tummy pain and other vague symptoms do not need a stool sample. It's quite simple. And we have until recently been testing stool samples that have got, that are completely solid. And we've stopped that because I went to a conference in America and they were like, why on earth would anyone ever test a stool sample that didn't actually look like diarrhoea? So when you submit stool samples to us, it's for gastroenteritis diagnosis. It's not because someone's got a sore tummy and they're anxious about work. We're all anxious about work. And this is an example. I was on holiday and one of my friends phoned about her daughter, 7-year-old. She'd had diarrhoea months ago that was self-limiting. There'd been a bereavement in the family that had opened up some old wounds, and there was quite a lot of stress. Little girl had some intermittent tummy pain that was isolated and actually probably was a little bit related to that, or who knows, it might have been related to school. Anyway, mum took the little girl to the GP. The GP requested stool samples. The stool samples came back with VTEC. The little kid, the youngest child that was at daycare, was excluded, even though completely asymptomatic, excluded until that younger child could be shown to be VTEC negative, and that's public health rules. You know, that's legislated, so you can't argue your way out of that as much as one would like to. So these are sort of the unintended consequences of sending samples off where there is no clinical indication. Because you've got to remember, our technology is actually in some ways more advanced than our knowledge about things. So we have PCR testing now for most of our stool stuff. So we've got PCR, so we get the sample in, and Monday to Friday you get a result within 24 hours, which is actually a very good turnaround time. So CAMP, Salmonella, Shigella, VTEC, Giardia and Crypto. And what was really interesting when we introduced this, because we used to only do Giardia and Crypto where you guys specifically requested, well, 30% of the Cryptosporidium cases that we picked up once we introduced routine testing had never, the parasites had never been requested. So we actually picking up quite. Public Health said to me, "What on earth is going on with Cryptosporidium?" And then we realised it was just that we were doing testing for it that hadn't been done before. And then if we get those positive for those bacterial pathogens, we culture, and then we do routine culture for Yersinia. Rotavirus is only done on request, and that's because the availability of the rotavirus vaccine has just plummeted the numbers of rotavirus in the country. Although in a meeting the other day, some of my paediatric colleagues did say that we might see it sneaking up again next year, so we do need to be aware of it. But there's a lot less rotavirus out there outside now. This just shows you that we just changed the testing method, that everyone got tested for the VTEC genes rather than the organism. It's too complicated to go into in great detail, but it's actually quite a hard organism to detect. So just by changing our testing method, we doubled Public Health's VTEC workload. And those potentially negative consequences for patients and families and daycare and people at work. Coughing, I'll talk about this very briefly. When I said before that demand management is around appropriate allocations of resources, well, this is my big thing that I'm annoying everyone that I possibly can, like my boss, about at the moment, is that we don't have pertussis PCR at Labtests because we are not funded to do it. It's funded to be done at Lab Plus, but obviously that's not their core work, and when they start getting too many requests, then they just sort of say stop sending them. So I actually think it would be fantastic for urgent care and GPs to have ready availability for pertussis PCR for patients that are presenting with cough 2 weeks or any of these other features. And I think that would make a genuine difference to patients' lives and their families' lives and workplaces, rather than doing chlamydia and gonorrhea testing on middle-class, middle-aged women with their pap smears. And if you look at the thing, we're due for, it's a little bit hard to see from that, but that was the last epidemic, 2011, 2012, I think. We're due for another one this winter or next winter. So when I keep nagging about saving money and not doing unnecessary tests, it's not actually that I want to pocket more money. The shareholders do, but I want to do pertussis PCR. Legionella serology, best avoided. And also the whole antibiotic thing, which I'm not going to go into, but I did this nurse GP talk the other day, and we were talking about antibiotics, and they said we get a lot of pressure from parents and antibiotics. I said, just tell them to make some fat. And they didn't, they laughed and they didn't really believe me, but there's quite good evidence that antibiotics, if your mother took antibiotics while she was pregnant or antibiotics in the first couple of years of life, causes obesity or contributes to obesity in children. So I think that that's a way of reframing that discussion. I think this is my last thing I'm going to say. My boss, and he told me that I was allowed to say this, my boss is in his early 60s, and he got very, very sick before Christmas and eventually was diagnosed with Legionnaire's disease in Hastings and had to go to ICU and was quite sick actually. He was phoning me and I thought, anyway, it turns out he was delirious. But he was my boss, so I didn't want to say, oh, what the heck? Anyway. He went to the GP after he collapsed at home before he was frankly so unwell that he had to go to the ICU with hypoxia. And the GP did B12 folate, ferritin, thyroid function tests, PSAs. I don't know that yes, he did lipids as well, in someone who was acutely unwell. And it's just crazy. There were enough B12 folates done in Auckland last year so that 1 in every 5 people in that Auckland population had a B12 folate done. And there's folate in the bread, I think, is there? It's just, there's some tests, and they're cheap tests, and that's why no one in the labs have never really, they thought, you know, it's too much effort. But actually, we shouldn't be doing tests that are just kind of reflex testing, B12 folate. Or honestly, when GPs call me to talk about a chlamydia result or something, and I look at it, and almost always, invariably, the patients have had B12 folate, ferritin, TSH, Not the women don't have PSAs. Lipid testing, HbA1c, all done in the past. So I think we just need to be a little bit more thoughtful. Blood cultures, oh, this is my very last thing. These well-meaning programs, these are the throat swab lobbyists. So these are the throat swabs that come from the non-rheumatic fever prevention program group. So these are not the schools, these are not the pharmacies, these are not the high-risk clinics in the poor areas of Auckland. These are just the normal GP and urgent care throat swabs. Whenever that was, 2011, 60,000 per year. Last year, 200,000 per year. There's been no change in Group A Strep epidemiology, but that is the huge increase in throat swabbing as an unintended consequence of a very well-meaning program. And along with all those, because remember, 15% of your throat swabs will grow Group A Strep regardless of the underlying etiology of the sore throat, because it's a coloniser. So there'll be quite a lot of antibiotic and childhood obesity being caused by that, because we're none of us are particularly good at not responding to positive cultures. None of us are particularly good at getting a positive culture and going, oh, well, we'll just ignore this. I'm not going to talk about this because I think we're running out of time and it's not micro, but we are going to start looking at ESR requesting in line with other laboratories. So most other laboratories in the country actually restrict it. We can't restrict it because of the way our computers are set up, but we are going to try and do some education around that. And these are some of the consultation documents that have gone out recently. And as I said, if anyone hasn't got those, because we have a lot of trouble getting information out, please contact me and I can get you in the system for that. So my concluding remarks is that the clinical diagnostic lab is not a free supermarket. You know, obviously something could change in the future and all of a sudden everything could cost a cent instead of $10 to do a test, and then perhaps demand management will not be a big issue, but it is an issue at the moment. It's an issue that's been discussed at all laboratory meetings through the country. Medical interventions are not without potential risk, and in particular doing chlamydia and gonorrhea tests on women who are low risk, and not all positive microbiology results require antibiotics. And at that, I thank you for your attention. Welcome questions.
Okay, you guys have 5 minutes to have some questions. So you got some questions, Steve? Let's start with him.
If there is concern over antibiotic overuse and things like that, why no rapid strep test to?
Oh, they don't work very well. We did a study, and it was quite interesting actually. We did a study a couple of years ago with Dinny Lennon and her group in South Auckland. And we got both false positives and false negatives, and I couldn't believe the false positives because we assumed that with those sorts of rapid test sensitivity would be a problem, but we actually had a problem with false positives as well. And then the nurse, Lizzie, who's fabulous, and she's been working in that area for the last sort of 25 years, she said, this doesn't surprise me at all, Arlo. We saw the same thing when we looked in the 90s. And then more recently, my colleague David Hammers looked in Northland, and same thing, he phoned me, he said, oh my gosh, we're seeing all these false positives. So they're just not that good a test. We have looked at and published data last year from a more rapid molecular test, but it costs and again, it picked up more, definitely picked up more, but there were some specificity issues. But it cost probably about 5 or 6 times what our current methods cost, so completely unaffordable. So, and also you've got to remember with group A strep, it colonises our nasopharynx, so you can have a sore throat from virus and have a throat swab and it will still grow group A strep. So the important thing is the messaging around who should get antibiotics for group A strep, and it really should only be very sick people or people at risk of rheumatic fever, Māori, Pacific, children living in crowded homes. Thank you.
There's a question about the urine testing using a bag, like especially for the kids.
Oh yeah.
Yeah, is there any point doing that? Because with 80% of cases they come as like contaminated specimen or mixed growth thing.
I think the whole bag urine thing is really fraught, and this is an example of where the real we work in the you guys work in the real world rather than the perfect world. So you kind of unless there's going to be the alternative is an our catheter or a stabby stab, which yeah.
cannot do it in the community.
You can't do, no. So you do the bag urine, you get the result, you look at it and you go, mixed culture contamination, or you go look, it's heavy growth of E. coli, and that fits with what I saw clinically. And so it's just that whole thing about the imperfection. So yes, no one likes them, but we don't have a better alternative.
Thanks. The bulk of your tests, the bulk of your talk is aimed at reducing unnecessary laboratory expenditure as far as you're concerned, as far as your company or shareholders is concerned. But I do understand and I do appreciate that there is a good basis to it, that there are too many unnecessary tests to be done.
But I would clarify that I'm not going to say anything for the shareholders unless I believe it medically.
Okay.
Yep.
However, I do have a concern about your approach with respect to urine testing.
Yep.
Even though we have charts in our collection rooms there describing women how, to women how they should obtain a sample, etc. I think to actually say that you're going to reject samples based on epithelial counts is fraught. I think there are cases where it's definitely justified in terms of recurrent urinary tract infections when the diagnosis is uncertain, etc. And I think you're actually very wrong if you proceed down that route. That's the first thing. Secondly, if you are going to proceed down that route, would you then offer the facility in your collection depots where you guys will obtain the samples to your satisfaction, even if that means sending a nurse in with a patient?
Thank you very much for those points. So firstly, that was not like this is what I'm going to do. That was something that I was sort of a discussion point. And I take on your feedback, and I think that that's really important. Why I don't think we did this at the beginning of Labtests, and what we have kind of developed in the last, particularly in the last year, is this consultation process, which is not just consultation, but actually it is a genuine process, because I don't know what happens in primary care unless you guys tell me. So I take your point and I appreciate that. Providing extra resource in the collection centre is a very, very difficult thing. I mean, they have this thing in the UK where it's this little, I can't remember what it's called, but it's a little thing you slot in there and then you pee, and it basically completely reduces the contaminated urines. But it costs about $1 or $2, I think, for each thing. It's a disposable thing. Well, I would love to see a world where we had fewer unnecessary tests, and then some of that resource could go into making sure that the tests that we have are more appropriately collected. But do I think that that ideal world's going to eventuate? So don't worry, the likelihood of restrictions around those epithelial cells is slim, and there would be a full consultation process, and I appreciate your feedback.
Anybody else got a burning question? Just down there.
Oh,
What was the question?
wound swabs.
Wound swab.
What specifically about wound swabs? Do we like wound swabs? Oh, you know what? You can't really. I think you can't on the basis of what we report. So it's more of a clinical thing. And I think that with wound swabs, say if you have some young kid who falls off a skateboard and then he gets an infection and he's otherwise well, there's going to be a staph or a strep, and you treat with flu clots, and the only reason you do a swab is to really exclude the MRSA, and it's got pus and it's really easy. That's fine. No one has a problem with that. But it's the chronic wounds, isn't it? And again, this is an area where I think nurses are a lot stronger than us with it, because they see it. The district nurses see it all the time. But really, what I've always been taught is that you're only supposed to use systemic antibiotics if there's surrounding cellulitis, systemic unwellness that you think is due to that, or there's good evidence that the healing has gone backwards and there's no other reason for it. Because I know it's really hard for you guys, because the district nurses do the swabs and then you have to respond to them, and people phone me and I say, look, you're not going to want to hear this, but I actually think you have to see the wound before you can make a clinical assessment and decide whether you're going to give antibiotics or not. So I think it's incredibly difficult, because it's a place where the management of those wounds has been pushed out of the GP practice into the community, which is probably appropriate, but you shouldn't be asked to make those treatment decisions on the basis of those results, because I think they are uninterpretable without the clinical scenario.
Hey guys, I need to wrap it up because the people are waiting outside now. So I'm going to wrap it up. And thanks very much, Arlo. That was a fantastic talk.
Thank you. It was a pleasure.